Schulman is Professor of Medicine at Stanford University School of Medicine and Professor of Operations, Information, and Technology at Stanford Graduate School of Business. He serves as the Interim Division Chief for the Division of Hospital Medicine and Associate Chair for Business Development and Strategy in the Department of Medicine. Dr. Schulman is a faculty director of Stanford's Masters of Science in Clinical Informatics Management program and the deputy director of the Clinical Excellence Research Center, CERC, at Stanford University. He also holds a courtesy professorship in the Department of Health Policy. An internationally recognized expert in health economics, health policy, and healthcare innovation, Dr. Schulman has significantly shaped research at the intersection of business, medicine, and technology. With over 500 publications, his influential work has appeared in prominent journals such as the New England Journal of Medicine, JAMA, and Health Affairs. Dr. Schulman serves as Editor-in-Chief of Health Management, Policy, and Innovation, and the Senior Associate Editor for Health Services Research. He is actively involved in translating research insights into practical health policy solutions and has served on numerous national advisory panels, including committees for National Institutes of Health, Centers for Medicare and Medicaid Services, CMS, and the Robert Wood Johnson Foundation. His work focuses on driving healthcare efficiency, reducing disparities, and fostering innovation through effective use of health information. He earned his BA from Dartmouth College, his MD from New York University School of Medicine, and his MBA with a concentration in health management from the Wharton School of Business at the University of Pennsylvania. Please give a warm welcome to Dr. Schulman.
Thank you so much for that generous introduction, and thanks for inviting me to participate today. So as Jason said, I'm now at Stanford University. Before that, I had been at Duke University. I've had the chance to interact with Dr. Wong before. What I'm going to talk to you about today is our next two sessions are going to be focused on AI. We talked a little bit about AI yesterday, and then I'm going to try and give you some ideas about how we think about AI in terms of education and in terms of opportunities. I titled this Building a Business Case for AI because at the end of the day, we want the technology to serve us, to be cost effective, as we just heard, and to help us achieve our goals in terms of the healthcare system. So I've been at Stanford for 7 years now after Duke. And one of the really interesting things about Stanford is how the university thinks about innovation. There's a very specific idea that we start with this idea of needs. How do we understand the problems that we're trying to solve and then think about solutions to those problems? And it's interesting in thinking about our lectures yesterday, we heard a really interesting idea about needs-based innovation from the first lecture that we had. And the question was, how do we improve the quality of care for cancer patients here in Taiwan? And the answer ended up being a multidisciplinary team here at the Cancer Institute. So we started yesterday talking about the solution, but we didn't talk about how we got there. I imagine we got there through this idea of, I have a problem, I'd like to do a better job taking care of cancer patients, and came up with the solution. So needs finding is the first part of the innovation pathway, and really critical piece of that. And then we'll talk about solutions. And solutions is where AI comes in. Because what AI has done is expanded our solution space. So if you think about 5 or 10 years ago, when I had a problem, I had X number of ways to solve that problem. Now with AI, I have a lot more opportunities to think about ways I can solve that problem creatively. Clay Christensen at Harvard Business School has also talked about this idea about needs-based innovation, and in his vernacular, it's talking about the jobs to be done. How do we identify our needs as consumers and then solve those problems? At Stanford, we have a program called the Biodesign Program. This, again, brings forward this needs-based innovation model, and I'm going to talk about just very briefly and show you how it works. One of the teams in our needs-based innovation program is focusing on cardiology, and they identified a problem that patients didn't like to wear Holter monitors, the monitor to look for cardiac arrhythmias after their discharge. And so their thesis, the problem that they identified, which is still on the website of this company that's now a public company, is they're designed to be comfortable and easy to wear for better patient satisfaction and compliance. So here's our problem statement. How do I get a patient to be able to be comfortable wearing this monitor? And the answer is, once they identified that problem, they built the solution, which ended up being this technology called the Zio patch. And as I said, now this is the standard of care in the US. But it started not with the technology. It wasn't with, here's how I can do an easy EKG. It started with the problem. And so every healthcare system in the world only has three problems: cost, quality, and access. And everybody is grappling with those three sets of issues. Historically, a lot of the work at Stanford in the needs-based innovation is focused on specific clinical problems like we just talked about. What's really exciting, especially when we're thinking about AI, is to take this idea of needs-based innovation to these larger macro problems. How do I think about solving problems of cost, quality, and access? How do I focus our identification of these problems and then build that into a solution? Once we have the need, how do we build an answer? And so this is a catalog of different ideas that are currently being researched at Stanford and in other places about how to do that. And what's really interesting, there are different ideas how to go from need to, frankly, scalable solutions in the marketplace. So at Stanford, one of the schools at Stanford is, we call it our design school, and it's this idea of starting with the needs that we identify. We would then go off and brainstorm what a solution could be. And that's been very, very successful. And so if you have really focused teams and really dedicated teams with talented advisors, we can come up with an idea about how do I solve this problem? And then we can go test that. Scott Brady at Innovation Endeavors in Palo Alto off campus teaches at the business school, and one of his observations is our students come to Stanford, the incredibly talented students like your medical students, and in this process of brainstorming how to solve this problem, sometimes they don't come up with the right answer and they get very frustrated. And so his idea is, how do we start and incubate, making sure the students are focusing on the right problems? And we've been working on this in the classroom this year. We assigned actually our students who have to do a research project 9 different problems. As Jason said, I'm interim co-chief of hospital medicine. So we asked all our faculty, you don't have to work on this, but if someone could solve a problem for you, what would it be? And we fed those problems to our students. Clay Christensen has coined the term disruptive innovation, and his idea of innovation is how organizations really come into markets to change the way markets develop. Really interesting ideas of innovation that you come in where specific market characteristics, where you find that the markets overbuilt technology especially, and there's an opportunity to come in with new technologies. Will Mitchell, one of my former colleagues at Duke and then at the University of Toronto, actually focused much more on how do firms change. With Clay, we have an idea about new entrants into the market, and we all know the name of these amazing firms that weren't here 5 or 10 years ago. But there are other firms that actually have been in that market and have been successful the entire time. And how did those firms change and respond? And so that's called organizational innovation. How do firms change over time? And that's also a really exciting area of innovation. Richard Foster was a consultant at McKinsey, and in terms of in his work, the solutions actually weren't necessarily technology solutions, but were changes in business models. And so we drove by Costco on the way over here. So here's a model for an innovation, which is how do you do low cost, goods and services at a retail level. And they didn't build new technology, they just delivered a different way, a different experience to the consumer. And so Foster called that business system innovation. And we, again, next to Stanford is Sand Hill Road and the venture capital community. And they have a different idea, a little bit more Machiavellian, which is give a little bit of money to lots of teams and see which team can work together. And if they can work together and if they can find a solvable problem, then invest in those people. And so it's a very competitive model of giving a little bit of resources to a lot of people and then see which one you want to advance. I'm going to talk about today, I'm going to talk about 3 case studies, and one of those case studies is with one of my colleagues at the business school, Stefano Senios. He has a new paper out last month in Harvard Business Review on something called precedent thinking. I'll talk more about that. But his idea is the way to solve this problem is once you identify the need, instead of sending your students off to brainstorm, how do I solve this problem? His idea is that every business problem in the world has been solved by somebody somewhere, and if you could identify a problem, why don't you look at how other people have solved it? And we'll talk about that for one of the largest, we applied that to one of the largest healthcare problems in the United States, administrative costs. And then finally, we have an idea, one of my colleagues, Nigam Shah, calls the moonshot. So as chief of general medicine, one of the questions is, what do we want to become over the next 5 years? We're living in a vision of what cancer care could be. And so right now, as the chief of hospital medicine, what do we want our practice to be over 5 years? And so we've started a project that 5 years from now, I want our faculty to be able to take care of patients without ever typing. None of us went to med school to type. And can we build a technology solution in a practice environment to accomplish that? So I'm going to talk about 3 different business cases. Talk about productivity. It's a case we're working through right now, which is trying to decide, again, to this moonshot, how do I make my faculty more productive? So that they can see more patients, they can spend more time with their patients, and spend less time with the computer. A second issue I'm going to go through is a really crisis in the United States on administrative costs, which you don't have here in Taiwan. But I want to talk about how we use this idea of precedent thinking to come up with solutions to that problem. And the third example I want to go through is something we call digitally enabled care. And this is to think about how do we just look at all the different services that we should get as patients that now technology can support that we don't get right now. And so I'll talk more about that. And that's a huge collaboration actually with a marketing professor at NC State University. So I'm going to start with my problem as a co-chief of hospital medicine. And this is this idea of productivity. How do we do more for our patients with the resources that we have? And we were talking yesterday about the differences between medical school and business schools. Business schools we all think about as, how do I make more money? But business schools are also maximization problems. It's not just about how do I make more money, how do I be more efficient, how do I improve productivity? Those are business questions, basic business questions. So colleagues at Harvard have done some work, Cutler and Huffman, and argue argued that in healthcare, at least in the United States, we have not seen huge labor productivity growths despite massive investments in health information technology. And the question is, why is that? And why that's so important is, on the right here is an update of our national health expenditures. Our population is aging, like your population is aging, our needs are growing every day, and currently we're projected to, our healthcare system is supposed to grow about 5.5% per annum. And so the question was, what would happen if we could get productivity growth of 1.5% per annum? I should say this idea came from Hillstead. It ran, and Hillstead said, well, when he looked at the retail industry in the United States with the adoption of technology, we had about a 1.5% per annum productivity gain from barcodes. So 30 years ago at the supermarket, people used to have to take inventory by hand. We don't have to do that anymore. We have much better order fulfillment. And so 1.5% productivity gain, where you see a massive shift in terms of spending over a decade. And then he looked at the telecom industry, and telecom had went from literally analog to digital, and went from copper wires to fiber optics, and as a result got about an 8% annual productivity gain. And Hillstead said there's no way healthcare would ever get that, but what would happen if we had half of that? And if that happened, you see our green line here, about 4% annual productivity gain, our healthcare spending flat. And this is the magic flattening of the cost curve that people have been talking about for a decade. But that means we have to figure out some way to get 4% annual productivity gains, which is enormous. So, as chief of medicine, of hospital medicine, what I need to understand, how do I improve faculty productivity? And that begs the question, what do our faculty do? What are the different jobs that they're doing? And at a high level, it's a bunch of these things that all sound very familiar to you. You know, we have to review the chart to figure out why the patient's in the hospital. Did they take this medicine before? Did we get the x-ray before? We want to summarize the data about that patient. We want to build communication workflows across a really complex multidisciplinary team. Unfortunately, we don't get around together. We have to build order sets. We have to do clinical decision support, note writing, and discharge planning. So our job is really complex and requires lots of different activity, or entails lots of different activities. And then every single patient who comes into the hospital has a journey, a complex journey that's kind of predictable, but again, different ideas of coordination that we have to do as providers. We have to, make sure the patients getting the consultants they need, the imaging they need. We have to interpret the data. A lot of conditional dependencies. Again, if the test is positive, here's what I have to do. I have to do a biopsy. And so, again, very complex activities. And the final thing that we're just starting complex set of activities. And so chart review. So how do I look through the chart? And this is, our Epic. I'm not sure if you're on Epic. But it's not a great technology. It's not very easy. So you could spend a half hour trying to figure out why the patient's in the hospital. And I want to contrast that with the plane that took us over here. And this is what the pilot sees. And the plane is also an incredibly complex system with the engine and everything else that's going on. But the pilot's not looking through the manuals the way we are, and not looking through even the raw data the way we are in healthcare. The plane's doing that for the pilot and just presents to the pilot what information they need to make decisions right now. So this is the heads-up display. Actually, Rob Califf, who we were talking about yesterday, my former boss at Duke, had an idea 25 years ago that he wanted to build up a heads-up display like this before we went into the patient room. So how do we think about looking through the charts, and can AI help me is one of the questions. So a patient comes in, can the AI help me summarize the chart, and so the physician's not spending a half hour, 45 minutes looking through the chart. Most of us get lab tests that look like this on the right with, you've you've seen the printout with the lab values, and then we have to figure out what does that mean. What does that mean that the grad needs 0.5 or 0.9 or 1.2? And really what the visualization would be, well, here's the GFR, glomerular filtration rate curve, and so here's where the patient plots out today, and you imagine if you actually got a graphical presentation of what the lab values were, rather than a static presentation. One of the other things we're realizing, we talk a lot about burnout, we talked a lot about delight yesterday. How do we get delight in the practice of medicine? And one of the things that's overwhelming all of us as providers, at the end of the day, our job is not just taking care of the patients, but is to integrate a lot of data, a lot of different data flows. And this is just a mock-up of what some of the data flows might look like during a different day on the hospital service. And one of the things that's really interesting when you look at the world this way is some of the data is not in the chart. In fact, a lot of the data are not in the chart. And so if you think about, I want to build an AI tool off the chart, can that automate my work as a provider? And the answer is no, because the information's not all there. And so again, how do we think about the needs and building solutions based on those needs? One of the challenges that we've identified on our service is that nurses and doctors are messaging each other very frequently. And so this is actually the actual data on text messages the doctors are getting for taking care of, in this case, I think it was actually one of our informaticists. He had a service of 6 patients and was getting texted like every 3 minutes during the day. And this is at Stanford. This is actually data that was published on the same thing. During the daylight hours, people are getting messaging all the time. And the question is why? Why are we using texting and these synchronous communication efforts to take care of patients? Obviously, one of the things I can't justify is paying a physician to answer text messages all day. And so we're trying to deconstruct that and figure out what is the business process that's being conducted through the text messaging, and can I build other strategies to support other technologies to support those messaging. In terms of order sets, if you haven't seen it, this is a typical kind of epic order set that we have. What you see here is it's incredibly complex, not very user-friendly, and so our physicians are spending a lot of time trying to figure out which boxes to click on this to order. In this case, this is what it takes to order a flu vaccine compared to the old days when you just wrote down flu vaccine. Clinical decision support's been a promise for a long, long time, and still is yet to make it to real time to clinical practice as much as we'd like. But this is just information about a patient comes in with an infection. What are the antibiotics that are recommended to treat this patient? And so on rounds, when we're in the hospital, the residents will take off their ideas about the antibiotic sensitivities and specificities. Why is it not a nice little graphical tool like this when the patient's in the emergency room? Oh, let me make sure I use the ones that are sensitive to at our hospital. So note writing is obviously the bane of everybody's existence. People, even with the electronic health record, I'm always signing my notes up to 9 or 10 at night when I'm on clinical service. And one of the questions are there ways in which we can make that easier for providers? And here's at least one study that said it didn't work as expected, that copy and pasted and templated text don't actually save much time for providers. And that leads to, in the US, our notes are getting very bloated from all this copying and pasting, getting less and less accurate, which means when I try to write an AI off the note, I have a huge problem in terms of validity. We did some work with ChatGPT. This is about, I guess, 2 years ago now. When it first came out, we went and said, can we use ChatGPT to summarize clinical vignettes? And then we tested that against our residents, and then we had our faculty actually evaluate that. So it was a really quick, interesting study, and the answer was actually, even at that time, the technology was doing a very good job of summarization. But as I just showed you, that summarization of the conversation with the patient is the least of what we're asking our doctors to do. This is one of the banes of my existence is discharging patients. And it's amazing to think about, but every single patient who comes to the hospital gets discharged. And somehow we never discover that until the day before they're ready to go home. And so this is what our discharge planning tool looks like right now. Yellow sticky notes on a screen somewhere. Order oxygen for this patient. Talk to the nursing home about this patient. And what I realized was, and I've been talking about this for a while, it's amazing. Every airline that lands takes off again, and the airline prepares for that because, and it's actually really complex. Turns out there could be up to 200 different activities between the plane landing and taking off again. That's all coordinated by software. No one texts each other. So imagine if we actually had the same kind of software to discharge our patients from the hospital. And this is a dream that I'm trying to get us to build right now. A is to move messaging from the bulletin messages that we use for discharge planning onto a better technology to do that. Where we could use we don't need to know, we need to know the status. Did physical therapy see the patient so I could discharge them? Was the home oxygen ordered? But all I need to do is be able to look at that. I don't need to know about that in real time. So what we just launched last week, this is very timely, is our effort is now called Hospital Medicine Labs. And our goal is to improve productivity and patient and provider experience. So our research shop in hospital medicine now is dedicated to this. I already told you our big project over 5 years we want to actually work on taking care of patients without typing. But we also want to use the tools available, of engineering especially, to think about better throughput, better discharge platforms, and our better communication strategies. So for this, I think AI is going to be part of our solution, but compared to the conversation we had yesterday, we're not ready to throw AI at this larger picture. We still need more work to do to define the problem and figure out where of each of these different pieces of this problem we talked about, AI could be of help. So I'm going to switch gears now and talk about a very American problem, which is our administrative costs. So we're very jealous of your system where this is not an issue, but it's an enormous issue in the United States. We spend about 1/3 of our healthcare dollars, if not more, on managing our healthcare. And so when we pull out an insurance card in the United States, we're paying 30% transaction cost. When we pull out a credit card, we're paying 2 or 3%. So we're massively overpaying to manage the system. And one of the issues that we point out is this is a typical insurance card in the U.S. and it's a credit card we all know. And I have my students look at the insurance card and just stare at it a minute and ask a question about what's missing. And then when they realize it, they start laughing. So here's an insurance card. There's no barcode. There's no chip. Our insurance system is entirely analog. It's been digitized, but it's an analog process that was digitized. It's not a digital first process like the credit card system. And so we've been doing a lot of work to try and understand why it is that we have an analog system that's digitized and how that leads to the cost that we see. Structurally, we also have a problem with our market that we allow customization of health plans. We're largely, we have public programs and private programs. The private programs are generally employer-based insurance, and our health insurance is customized to every employer as a way of selling health plans to employers. As a result, we have 3 600,000 units of service we bill for. As a result, we have about 57 billion negotiated prices, or 94,000 prices per service. Now you know why our healthcare costs, our transaction costs are 30% of our healthcare spend. And so what do we do about this? This is more work that we did to try and clarify this further. This is something called time-driven activity-based costing that we did with Bob Kaplan at Harvard Business School, where we built process maps of what it takes to submit a bill and then calculate how much it would cost us to go through each of these steps. And for a primary care physician in the United States, it costs $20.49 to submit a bill. We're an outlier. When we did that same work internationally, what we find is administrative costs are lower in other countries, and I like the Netherlands a lot. In the United States, we have a debate about whether we want to go from a multi-payer system to a single-payer system. Canada is a single-payer system, does have lower administrative costs, but Netherlands has a private multi-payer system that also has lower administrative costs. Politically in the United States, unfortunately, we're never going to vote for a single-payer system, but that doesn't mean we can't solve the administrative cost problem, because Netherlands has a private system like we do and has lower costs. So Bill Gates has this quote, first rule of any technology used in a business environment is that automation applied to an efficient system will magnify the efficiency, but automation applied to an inefficient system will magnify the inefficiency. And this is an inefficient system where we're now deploying AI against it and potentially can actually dramatically make this problem worse. So with Stefanos, we've been working on this idea about an application of what he calls precedent thinking. And again, this idea is that every business problem in the world has been solved by somebody somewhere, and if you figure out how they solve the problem, you can see if that solution applies to your problem. So about a century ago, an entrepreneur was looking to start a new business. I won't tell you what problem he was trying to solve, but here are the 4 innovations that came together to become this company. The observation that the meatpacking industry in the 1880s in Chicago was building up scale. The identification of a fast-drying black lacquer paint. The idea about selling sewing machines through something called franchises. And the idea of offering stock options to your employees. These 4 innovations came together to form a company that you all know. Anyone have any idea what company this is? What? No, not McDonald's. Ford Motor Company. So Henry Ford wanted to build a low-cost cars. Cars were very expensive and were custom built. And so his challenge was, how do I build a low-cost car? No one had ever done that before. And so it turns out the meatpacking industry had built literally disassembly lines to do meatpacking at scale. Henry turned that around and built assembly lines to build cars. Famously, he used to say you can have any color you want as long as it's black. And the reason was, at the time, the only paint that would dry fast enough to use on an assembly line was black paint. Isaac Singer's idea about sewing machines and franchising sewing machines meant that Henry Ford did not have to build dealerships all across the United States in order to sell his cars. He could get other people to invest in capital to build dealerships, which made his business model much more capital efficient. And then finally, the idea of stock options was really attractive to Ford, not because he wanted his workers to get rich, but because if they had stock options, they could actually use the money to buy more cars from Henry Ford. So precedent thinking has 3 components to this again. First is framing the problem. Again, we're going to start with needs-based innovation. How do we identify the problem that we're trying to solve? Then, once we identify the problem, we could say, who else has solved that problem or a piece of that problem somewhere in the world. And then we could bring those ideas back and say, well, those are really interesting ideas. How does that apply to my problem? And so we decided for administrative costs is how do we reduce the heterogeneity and complexity of this transaction process, and how do we create a payment infrastructure to support a much more streamlined process. And with a team of incredibly talented students at Stanford, we spent a year on this, we sent them out, we came back, and they found 82 different firms and markets that had solved some or all of a very similar problem at scale. And some of those were driven by the public sector, some were driven by private, some were driven by public-private partnerships. Of those 82, we focused on a streamlined list of 26 and then whittled that down some more. But this ended up being incredibly powerful. Compared to the yellow sticky notes that the students would do before this, these were innovations that occurred at scale that still impact us today. So, like I told you about health insurance, where we customize health insurance, household mortgages in the 1960s were also customized. Banks would customize a mortgage. And then there was a crisis at the end of the 1960s in terms of liquidity at the banks. And so the federal government set up two organizations called Fannie Mae and Freddie Mac, and their charge was to syndicate mortgages to allow capital to home lending. And when they looked at the market, there were all these one-off mortgages, not these custom mortgages. And so there was no way to package those up to syndicate them. And so the first job of Fannie Mae and Freddie Mac was to standardize mortgages in the United States. And they did this in 1970, and more than 97% of all mortgages today still rely on the standard contracts that were developed in that year. And the banks, of course, resisted this because their business model is based on custom mortgages. Banks still successfully lend mortgages today. Another government-led change was in aviation. So up till the 1950s, every airline had their own flight planning system. Okay, so the airline was responsible for air traffic control for their planes. And unfortunately, that meant that in 1956, 2 planes crashed in broad daylight over the Grand Canyon in the United States. And the government said, that's it. We're going to take that responsibility away from individual airlines and centralize that into what we know as the FAA today, and the central air traffic control system. Those were public efforts to standardize across an industry, but there are also private efforts. One I found really interesting is standard setting organizations. So in mobile phones, we sell 1 billion mobile phones a year around the world. The only way to sell 1 billion of a product is to have an incredibly standardized product. Now the challenge with an incredibly standardized product is who wants to buy a new phone if it's the same as last year's phone? And so the industry has to both standardize and innovate. And the way they do that is through these SSOs. So all the firms in the industry say you're building a modem for Apple's phones or for cell phones, because this goes across Apple and Android. Say you're building a modem. So we have 6 different modem manufacturers. They're all doing research all year about the idea for the next generation of their technology. They come together as an industry, and they all present their ideas about the best way to go forward. And as an industry, they pick one. And if it's my modem, you all owe me royalties. If it's your modem, I owe you a royalty. But we all leave the room to make the same modem. And that way, they solve standardization and innovation at the same time, and obviously tremendous success. And then finally, actually, another one that was pure private was the banking system. There's something called SWIFT, which is how banks pay each other. It was a really complex system that they standardized, and the private banks did this first, and they invited the federal government to participate. So we came back and said that actually there are lots of precedents on how to reduce standardized contracts and to reduce the complexity of our transaction system. And there are lots of different ways to think about the infrastructure that can support it. And so we're working very hard now to actually think about whether we could catalyze a private initiative in the United States based on these ideas to reduce administrative costs, or our federal government's very focused right now on administrative waste. Can they pick this up as one of their signature programs? One of the pressures that we keep getting back is, well, why do we care about administrative costs? We're just going to make health plans more profitable. And the question is, how do we reduce the cost to individual patients? And this is actually Stefanos drew this on a whiteboard. But the idea as an economist is if I could reduce standardized transactions, I could reduce barriers to entry, I could get more firms to enter the market, more competition, and that would drive down price. So that would be my answer. So and improve quality. So it's not that we're ignoring the patient at all. At the end of the day, we're thinking about how this innovation can drive to the patient benefit. And then we literally just published this in January. And then the third place I want to talk about in terms of building a business case for AI is thinking about what we call digitally enabled care. I wrote this with Stacy Wood, who's a marketing professor at NC State University in the United States. So when I'm taking care of the patient in front of me, that's one-to-one. That's very analog, but that's what we teach in medical school. When I'm talking to 10,000 patients, that's one-to-many. That's not the same thing as taking care of a patient in front of me. That's actually a marketing question. And so I've been engaging with Stacy to try and think about how do we bring insights from the field of marketing to how do we do a better job taking care of patients in population health. And to our talk yesterday is, can we think about a world that's both high-tech and high-touch as a synergy. And so we came up with a framework that we call the Digitally Enabled Care Framework, which is leveraging technology to improve the physician-patient relationship. So yesterday we talked about one or the other, and we think that it's very complementary. And this was a model that we put forward, and I'll go through this in a little more detail. But in most other parts of your life, we flew over here, and we're flying back, and 2 days before we got here, the airline started texting me and sending me emails and asked me to pick my meal, and asked me if I wanted to change my seats. So before the visit, before my flight, there was a whole bunch of pre-flight services that were provided. So the same way, we should have pre-visit services. Right? How do I help you get organized with it? Then there's a set of services we can provide digitally within the visit when you're seeing the patient either in person or by televisit. And the thing that's most interesting about this framework that I like is post-visit services, which is a field that basically doesn't exist and should. So when we're talking about how we improve population health, it's not going to be a lot about seeing the doctor in the office. It's how do I help you make sure you're taking the right meds every single day? And that's a whole set of post-visit services that digital is an amazingly powerful platform to use. So in the pre-visit, we want our patients to get active, to get ready to see us in clinic, to help improve their health literacy. So what questions do you have? How do I, this test, our patients could get the test results from the browser before they even come in. Well, what does that potassium mean? Or what does that creatinine mean? Give them some tools to try and understand. And then also, how do we make them comfortable? How do we reduce stress? And so we have lots of ideas about that, about creating an environment before they come in, and imagine and helping them to say, during this visit, here's what I want to get out of it. Here's the questions I have for Doc A. Maybe even talk to your children about that. What do you want me to ask the doctor today? During the visit, we want to build engagement, agreement in terms of shared decision-making, coordination. And some of this is actually the environment, especially if I'm doing a video visit. How do I create a digital environment that really is engaging for patients? And there's lots of really spooky marketing faculty, very creative, lots of ideas about how do I build screen designs and backgrounds, Zoom backgrounds, that are more engaging for my patients to meet them where they're at. How do I make sure I answer all their questions? So if we did this effort to help them articulate their questions, how do I answer all those questions? And then imagine we have a transcript available for the patient at the end of the visit so that they can actually, if they want to, share that with their friends or relatives. And then, as I said, post-visit is largely ignored, at least in our world. You can come to our Stanford hospital and spend 5 days with us. We'll do an amazing job working up your illness, and then we're going to give you a piece of paper at the end of that with all the information. And that's, it may not be in your language, it may not be at your reading level. No one reads. So we spend a lot of time on this. Another thing that we're getting is, we spend a lot of time on, helping the patients understand their medicines the last day of the hospitalization. Very important task. We have different people assigned to do this task. So after 3 days of taking care of your pneumonia, when you're sick in the hospital gown, you just can't wait to go home. The nurse is going to come in and explain to you about all your different medications that you're going to take as a chronic patient. And if anyone thinks you're going to retain any of that information, they're crazy. So what you should get at the time of discharge is a QR code. Here's where I'm gonna have a Dropbox folder with all your information and some nice videos to explain to you how to take your medicines. Imagine when you go home, you actually get information about your disease in your language at your reading level in video. We just ran an election in the United States that was totally based on TikTok videos, and we still hand out that piece of paper. So AI as a technology can do this now. AI is incredibly good at summarization. I can take source of content and transform that into a podcast if we want to, into a video if we want to. I could do the reading level. Our patients at our hospital generally speak 5 or 6 different languages. And so how do I can get it in their language at their reading level. The hospital want us to do the discharge plan with the medicines. So again, I can have a list of medicines, what the medicines look like, how to take them. For surgical patients, imagine that you have a picture of the wound every single day. This is what a healthy wound looks like. This is what it's going to look like on day 2. This is what an infected wound looks like. If it looks like this, call me right away or come in the emergency room. Why we don't do that is beyond me. But part of that is we've never conceptualized, how do I do a better job of this post-visit services. And now that we have AI, gives us a huge opportunity to really build out a suite of services to help us accomplish a goal. If it's taking care of the patient's blood pressure, their diabetes, their hypertension, giving them self-service tools. Patients that are engaged are much less costly to the system, they're more active in terms of taking care of their health. One of the things to realize in the marketing world, this idea of mass customization of services is very routine. And I like to talk about this, about Netflix and the Netflix business model. And so if you're on Netflix, you get a different set of recommendations than I do. But I hadn't realized, not only do you get different recommendations, but you get different images. So they customize both the recommendations and the images to make it more attractive to you. And obviously we could do something like that for our patients. And so another thing, I focus on Stranger Things here, and this is a Durham reference. So the Duffer brothers who did the show were from Durham. And so in the show, which is very popular in the United States, whenever there's an activity, it's always somewhere in Durham, like Cornwallis Road, there's all these different references. So imagine a world where we have all this content, we know a bit about demographic characteristics, so I can customize that content to you the same way Netflix does, the same way Facebook does, everybody else. I can take that content, and now I have lots of different interfaces. We've actually even studied, and I'll show you, using voice as an interface. The video can be an interface as well. And then we also have feedback. So you have a smartwatch. If I tell you to walk 3 times a week, I can actually figure out whether you responded to that or not. And if not, I could try something else. On the provider side, this is also really interesting because as we get to know more about you as a patient, I can be more informed as a provider and have some insights into language that I could use to help motivate you. And so the language that so I can come in with some hints about language that's going to fit you more directly. And this is actually some ideas, market segmentation we did in Thailand about care of parents. And this was a study we did of sending people home for insulin titration with Amazon Alexa. So we wrote a script to help Alexa manage your blood sugar. So I want to increase your dose titration over time, and this is what happened. So we sent everyone home with Alexa. Half the people got an Alexa program to help them with their dose escalation. Half just got an Alexa to listen to music. And what we saw was over the 2-month period, people that had the Alexa to help them with their dose titration made 7 different dose adjustments. And the people that had the piece of paper, the standard of care, were lucky to get 1 dose titration during that time. Why is it that we don't have these services right now? Has a lot to do with payment models, especially in the United States. And a lot of our system is based on fee for service, and we're starting to get different payment models and payment codes for digitally enabled services and for things like monitoring patients over time. But it's still based on monitoring means the nurse is monitoring them rather than me looking at a dashboard, digital dashboard. But as we wrote this paper, we sent it into the medical journal, and we got a review back and said, well, I'm curious. You talk about payment models for digitally enabled visits, but in the digital world, everything's continuous. And so why are you talking about discrete payments and not continuous payments? And so our next project ended up being on something called subscription models. And it turns out this is a really interesting concept that we all know very well. But thinking about primary care and prevention rather than as a set of discrete services as a continuous subscription. And then in the marketing literature, it turns out there's multiple different subscription models out there, lots of different ideas about how we could be creative. But if you had a Netflix for your healthcare, for your primary care and prevention, we could actually curate all this digital content the way Netflix does and feed that out to you, again, based on these tailored recommendations. And so as a primary care provider, I could actually be in charge of your Netflix subscription rather than you having to go find every one of these resources on your own. We could do that as a Stanford branded program, which would be really kind of interesting. But I think there's a lot of opportunities here to go back and say, well, I want these services as a patient. If I want to improve cost, quality, and outcomes, digitally enabled care is going to do that. I have to figure out a payment model that creates incentives. If we took 10% of our premium dollars in the United States and put it to primary care and prevention, every single tech company on in Northern California would be creating digital content for us overnight. So, we spent our time talking about building a business case around AI from healthcare, and Kurt, who comes up next, as the data scientist, is going to talk to you about the technology itself. But I want to talk about how do we find the right applications for this technology? Or we've just talked about how do we find the right applications for this technology. And again, it starts with needs finding. It starts with the problem and not the solution. AI is one of the solution sets. Some of the stuff I talked to you today doesn't need AI. Some of it just needs, different levels of medical assistance to do tasks. It's a really interesting time when we don't know the answer about which innovation model is going to be the most successful about bringing AI to the market. And so I think we want to have an opportunity to actually test out multiple of these different innovation models. And I think that's just as exciting as the technology. And I do want to say now is the time. And it's on a lot of different fronts. So one is the idea of this technology obviously caused us to have a conference here today, but it's causing everyone to stop and pause. Right? The status quo that 5 years ago we would not have debated doesn't feel comfortable to us anymore. And so there's not many times where as a society, as a global society, people are willing to adopt new things. And so we need to take advantage of that. In the United States, political change might be an opportunity to unstick parts of our market that have been very static for a long period of time. We'll see. It's an open question. Obviously, from a regulatory standpoint, the regulators and government are not leading the charge, but they are going to have to catch up and adapt these payment models to kind of go to the innovation. And I think we heard this quote yesterday about Wayne Gretzky, about skating where the puck's going to be. And I think that's the theme for us today. It's very clear this set of solutions is incredibly exciting and really gives us a huge opportunity to change going forward. So thank you very much. Thanks for inviting me.
Thank you, Dr. Schulman. We have actually representatives from the National Health Insurance here today. And they're here to hear about the business model, so your talk is particularly enlightening. And then also, you affirm my hypothesis that even though I'm at Stanford, every time I meet other Stanford faculty abroad, I learn a lot more about their work than when I'm on campus. Thank you for that. Any questions for Dr. Schulman?
If you have a question, there is a button right in front of you. Each seat in front of you has a microphone. Please just press it once, and then the microphone will turn on.
So, do you hear me right now?
Yeah.
Okay, thank you. I'm Xia Junwang, and Radiation Oncologist at National Cancer Center. And our university actually has a biodesign program running for about 4 years.
Hang on a second. Cut it out.
Okay. So sorry, I'll repeat. So our university actually has a biodesign program running for about 4 years. And we're actually keep thinking about an issue that we would ask for your suggestion. So you have mentioned that there are many different innovation models. And my question is like, how do we prepare our next generation of innovators with these different kind of innovation models? Because we think if we get them too much, like too many different models, then we will get confused. Only one, they will maybe miss some of the important models in that case.
Yeah, it's a great question. So the biodesign program at Stanford that we talked about that has a textbook and lots of people have these programs. And biodesign's been great, especially around technology and technology innovation and engineering from an engineering perspective. There's nothing wrong with biodesign in terms of the approach to building solutions. I think there's a chance to refresh that. So I don't know that I would use all of the different innovation models. I would be cognizant of those. This precedent thinking actually, so I guess it really kind of depends on what the problem is you're trying to solve. If you want to move away from a specific kind of engineering focused clinical problem to building solutions to these cost, quality, and access issues, at least our team one of the people on our team had worked with McKinsey and had been working on this problem for quite some years with other groups, and didn't think, she had been working on it and didn't think it was a solvable problem. And then we did the precedent thinking model, and halfway through that she said, oh my gosh, this is a solvable problem, I hadn't realized it. And so I think, part of it would be which kinds of problems you're trying to solve. And also a recognition, especially for students and startups, like, pick the right problems. So let them learn the innovation process, but the administrative cost work that I talked about is too large for students to do. So we also have to think about that as well. So I think the biodesign is a great place to start, and then just be aware there's other ways in which you can extend it.
Thank you very much.
Thank you for the question.
Hello. Yes. I'm Dr. Song from Taipei Medical University. Thank you so much for sharing us so many innovation in medical care. My question is about medical education. Can you suggest how we can incorporate this part into our curriculum of medical education, especially for undergraduate education? Thank you.
Yeah, so we talked yesterday about some of these business concepts, and there was an allergic reaction, of physicians to understanding business. We're not trying to create for-profit entities, transform the healthcare system, but these idea that we're working in large organizations with complex technology problems, those are all business problems. And so I think, everyone, all of our students should know a little bit about financing and delivery. Our goal is not to make our medical students the expert in any of these, but to know that there are experts in these fields and how to talk to them. And so, in the U.S. context, as a university, we have the med school next to the engineering school, next to the business school, and so I could have teams together. But even our colleagues up the street, UCSF, is a standalone medical school. But they still are going to have to do this. So I think we need to think about how do I introduce these topics, not to make them experts, but mostly so they're not scared of these, I remember I was terrified of accounting. And actually it was one of my favorite courses. But as a pre-med student, like accounting is like for those other people. But I think we need to think about how to do that. And then some small group of them are going to be really excited and want to do more. But everybody else really just needs to be exposed so that when they see a problem, they say, oh, this is an optimization problem, it's an engineering problem, it's a marketing problem. There are other people who can help with that.
In the interest of time, I think we're going to move to the next session. Thank you so much, Dr. Schulman.